All right, so I have the honor of being your moderator this morning. It's nice to see everybody. I'm Nicholas Tetnetti. I'm a professor and vice chair of computational biomedicine at Cedars-Sinai Medical Center. And a couple years ago, had the honor of talking and being on here and telling you a little bit about what I do. But I'm going to that's it for me. I'm going to keep myself brief and try to keep us on time. So speakers, I'm looking at you. But I have no problem, we'll do that. First up, we're gonna have Dean Noble-Tolla, and I asked everyone, which is actually just Dean right now, for a little bit of a tidbit that nobody might know about Dean, and he said nobody knows or would guess that he's from the Deep South. He's worked hard on his accent, apparently. Did you have an accent at the beginning? No, you never had an accent. No. All right, everyone, join me in welcoming Dean Noble-Tolla.
Hi, everybody. Hopefully this thing's on. Okay, sounds like it's on. I actually once told a coworker I'd been working with for 5 years that I was from Georgia, and he asked if I meant the country. So, how about this conference, huh? This is really impressive. I've never been here before, and I've never seen such an interesting mixture of, clinicians, fundamental researchers, public policy, advocacy, and I've learned a lot, and I hope I have something to contribute to that with these slides. Okay, don't lean too far away from that. My company is Prealize Health. We're a startup in healthcare. We're a for-profit company, venture-backed out of Silicon Valley. We have about 30 employees, and what we really work on is trying to advance proactive care. And by that I mean, probably give a little context, most of our customers are either health plans, health systems, or some specialty care management companies. Uniformly, though, all of them take risk in healthcare and are financially responsible for outcomes. And so what they are all interested in is how do I improve the quality of care but lower the cost or keep it steady? And so our piece in that is really around predictive analytics. And now we're going to see if the slides go forward. Cool. So our mission is to transform healthcare from reactive to proactive. And our research and founders, I should say, our founders are Professor Nigam Shah and Professor Arnie Milstein out of Stanford. Arnie's research is largely around how do you improve cost and quality in care, and he's been an advocate in that space for a long time and influenced quite a lot of public policy. Professor Shah's lab is on the application, focused on the application of AI and machine learning in healthcare. And he is also currently the Chief Data Science Officer of Stanford Health. So it's his research that we leverage in order to make our predictions. I want to give a couple anecdotes to help make this sort of more tangible. So we have a lot of healthcare claims data. That's mostly what we work with. And when we look inside of that data for things like who shows up in the emergency department for the very first time, the number one reason they come in is an anxiety diagnosis. So these are people who start with a panic attack, quite reasonably think that they're having some kind of cardiovascular event, and then very reasonably go and seek emergency care. This is like a really expensive way to realize that you need to get in contact with a therapist, right? And I'll give a second one, which is when we look at all the people who ultimately get a musculoskeletal surgery, and I'm talking about like hip, knee, shoulder, spine surgeries, that's usually a journey that takes about 2 years from an initial diagnosis of some musculoskeletal variety, commonly pain, to a surgery. And so they probably start by going to a primary care doctor. They probably go in for knee pain, for back pain, et cetera. And in that course of the 2 years, only 30% of them actually try physical therapy. The other 70% never even attempt it because no one ever directs them to it. So there are like tangible things that we can do here if we can get ahead of these risks. I want to just add one note here. We're not a generative AI company. We are focused really on predicting risks in healthcare. And I'll talk a little bit more about how our model works and what we do. But we aren't in this realm where we're going to hallucinate things that are factually untrue or any of that stuff. So this is a little bit of a timeline of some of our company history. So we were founded in 2015. But in 2023, Professor Shah's lab was doing research on how do you apply transformer models to healthcare data. So this is the kind of model architecture that underlies a lot of the advances that you've seen in AI in the last few years. And most of those models focus on things like sequences of words, sequences of images. But he had a student in his lab who was focused on how do we Make sure I'm on the right side of the line. How do we deal with sequences of healthcare information? So we were aware of that research before it was published. We quickly turned that academic research into a production model for our company, which we call Metis AI. We launched it in late 23, and by the end of that year, we were already in a position to replace all of the other predictive models that we had, which were over 50 XGBoost models, if you're familiar with those types of models. One of the upshots of this, which I'll talk more about, is it also provides a timing estimate of when these events are going to occur. And then in 24, we spent a lot of time figuring out how to scale that up to initially 5 million lives and then eventually 300 million lives, which was not a small computational feat. And this year, we've worked a lot on expanding the predictions that we're able to produce and generating a new sort of set of social risk predictions, as well as geospatial risk predictions. Let me talk a little bit about these different types of models that you see in healthcare. So that first column there that I've called traditional predictive models, this is stuff that's been around for a long time. These models are linear. They don't account for time. You can think Hopkins ACGs if you're familiar with that, DXCGs, Optimum Impact Pro. Somebody whose timeline is an increasing risk trajectory as a sequence and somebody whose timeline is a decreasing risk trajectory, they look exactly the same. That stuff in the middle is something I've done a lot of over my own career. Think of it as kind of like bespoke machine learning AI training. You pull together one data set. Let's say you want to make a model that predicts emergency department risk. You get the data together for that. You train one predictive model on that, and that's it. It's one-to-one type of mapping. The thing we do with Metis AI on the right, we're actually going to pull in everything we can see about an individual and turn that into a timeline for them. So think they had an ED visit on a particular day, they got a drug filled on a particular day, they went to see their primary care physician. We're going to document both the procedures that occurred during that, CPT codes if you're familiar with those, and the diagnoses that occurred during that visit. We're going to do that for everyone in the population. And then we're going to remove some of those events, and we're going to teach the model how to fill them back in. This is our unsupervised training step, where basically we are trying to make a foundation model that understands the events and timing of events in healthcare. That's the goal. What we get out of that is this 150 million plus under the hood foundation model that we then are able to fine tune specific predictive endpoints off of. So we don't make 50 plus different models anymore. We make one foundation model and we fine tune it for the specific risk predictions that we're interested in. One of the upshots of that at the bottom you see there is that it makes it much easier to add new predictions into production. Last year we added 15 additional predictive insights. It's better at low frequency events. So we only need 24 examples of the thing we're looking for in order to successfully train a predictive endpoint. And we're able to identify a lot more of the risk. And yes, it is more accurate. This is a little bit of a look at kind of how data flows through our system and what we do with it. So we pull in medical claims, we pull in pharmacy claims, we pull in lab data from some customers, electronic health records from some customers, engagement and outreach data. I want to know who in the population is actually likely to engage with an outreach attempt. Stuff in blue is from our customers. Stuff on the right here, we have access to a 300 million life claims data lake that we're also able to train on and supplement information from. There's some restrictions on how it can and can't be used. Don't worry about the purple box. I'm going to show you all the predictions in just a second. In the gray there, what we're really trying to accomplish is to integrate directly into existing clinical workflows. There's no reason that someone should have to find our predictions by having to pop up an additional tool. It's a disruption to the way things work. So we integrate directly into existing tools. We do custom API integrations. We do batch deliveries into data warehouses. We have our own software. All the above are options. We just want to get it in front of the people who are actually trying to mitigate and do outreach to the risks that we're predicting. HITRUST is a certification. If you're not familiar with it, it's an external auditing process that we have to go through to make sure that we have the appropriate compliance and law and rules in place to be able to handle PHI and PII data. This is the library of things that we are able to predict on. So you don't have to read them all. It's like a bunch of information. Right. Also, the slides will be available later. But to orient you, the top left here is all about cost. who's going to become expensive, who's going to have a cost increase, what are individuals going to cost, what are aggregate groups of people going to cost, how many people are going to go over $50,000, $100,000, $150,000 in a population, et cetera. On the right, it's all about use. So specifically, who's going to end up with an inpatient admission, an emergency department admission, or musculoskeletal surgery. And along the bottom here, this large library is the thing that expands the most over time. These are all condition-based predictions, and we're actually predicting that this person will come in and seek care for these specific conditions under the hood. That's all mapped to ICD-10 diagnosis codes. Right. So for example, in our former model generation with XGBoost, we used to do stuff like predict someone will show up for behavioral health. We had to do it at that level. It didn't matter if it was anxiety or schizophrenia. But now, because of the advent of this new Metis AI model and being able to use transformers in healthcare data, we can actually split that up. So we can separately identify people who are going to show up for anxiety, mild, moderate depression, severe depression, mood disorders, and psychosis. Not everything works, though, by the way. We tried eating disorders, and it was totally underperformed. In addition to those clinical-related risks and utilization cost risks, we also do social risks. So here we predict at an individual level, based on matched member data about that person. What are their social risks? Do they have a food insecurity problem? Do they have a transportation risk? If you see these ones here that say access, like ambulatory care access, hospital and emergency care access, these are purely geospatially based. We take an individual's address, we map the resources in their immediate environment, and we make an assessment of how close they are to those things. It's something much more precise than, say, using a zip code level social risk score. Down here at the bottom, not quite a social risk, but we do also do engagement predictions. So this is based on training on data that we get from our customers to identify who else will respond to a phone call outreach, a text message campaign, and so on. That's like awesome. We can do lots of predictions. That's great. The people who use our predictions don't really know or need to know everything about how they work. We actually want to put these things into a position where they are informative to what they currently do. And so just to give you a sense, we take that library of predictions, which is sort of like, just think of it as a large platform, and we package that up into three main use cases: care and condition management, financial risk management, and member engagement. I'm going to focus on the first one for this. We can talk more afterwards if you guys want. This is an example of what this looks like through a process that we call case selection. So imagine that I've got a population of 1 million individuals. I've created that entire library of predictions for every single person in that population. We actually do that every month. I've got, in this example, this is all historical, so I have the full outcomes period. I know everything that happened. I have full 12 months of history of what happens after I make these predictions. I also have 6 months of claims run out. If that's not meaningful to you, don't worry about it, but you need to know that claims data is extremely lagged in time. This particular example, these are like custom configuration things that come up for our customers. We excluded anybody who was pregnant, anybody who had a cancer diagnosis, anybody who had a recent inpatient admission, and anybody who was already over $50,000, because these people are not interesting to our customers because they already know about them. They don't need our help. That first circle you see there, where it says new high cost, this is a prediction that the individual is going to move into the top 10% of the cost distribution in the next year. They're not that expensive today, but they're going to become expensive. Individuals like this drive roughly 15 to 30% of all healthcare spend. It's not a small portion. So in a given month, we might identify about 4,150 people that we are confident that that is going to happen to. And since I have the outcomes, I can tell you 87% of them actually did have that outcome. We also train that engagement prediction. In this context, this is quite common for health plans. A lot of this is telephonic outreach. These are actually nurses calling people in the care management arm of a health plan and trying to proactively engage these individuals and get ahead of their risks. So we want to find the people who will actually respond to those calls. And this is a very resource-constrained problem. They can only do so many calls a month. So we threshold for 50% or higher likelihood to engage. Clinical impactability is actually not one of our AI predictions. It's a bunch of clinical rules under the hood. So we had a physician council help us with 190 plus clinical rules. We turned that into a 1 through 5 rank. So 5 is you can do a lot to alter this person's risk trajectory, and 1 is you can do very little. Because this shouldn't be surprising, but this new high cost model is really good at picking up extremely obvious stuff that you can't do anything about. So what do we want? Pretty obvious, right? Venn diagram of these 3 things. I want to know who's going to become expensive, I want to know who will engage with outreach, and I want to know who you can actually do something about. This is kind of the base case scenario that we start with when we go to stratify a population for proactive outreach. But what happens over time is all those other, diagnosis-based clinical risks I showed you, our customers come to us and say, that's great, but can you also show me individually who should be prioritized for mental health, who should be prioritized for cardiovascular health, et cetera. So this gets carved up over time, but this is kind of the simple version. Those people in the middle are the ones that we actually surface on a regular basis as prioritized members for outreach. And this is what we surface, to the care managers who are actually looking at this stuff. So this would be member level information on the individual. It would have their name if this was a real case. This is the probability that we just talked about of the member becoming newly high cost. We also do a jump in cost prediction. So this is the probability the member is going to increase by $5,000 or more year on year, $10,000 or more year on year. Doesn't matter where they start. So we want to catch the people who are going to have cost escalations regardless of if they're already expensive. Highly likely to engage and highly clinically impactable. Beneath that, we then surface more of these insights that we were showing earlier. So here I'm actually saying this person is going to show up and seek care for COPD, and it is 1 to 3 months from now. We were able to bin that into 1 to 3 month intervals. You're probably wondering how accurate that is. It's correct about 75% of the time. We also are flagging them for like a fall and fracture risk, right? 10 to 12 months out. They have mild, moderate depression they're going to be seeking care for, also 10 to 12 months out. Below that, we surface those utilization-based drivers. So this is an emergency department visit for an ambulatory care sensitive condition. These are about 19 conditions that you really should treat in primary care and not show up in the emergency department for. This is like going to the emergency department because you have asthma, right? It's a very expensive way to get care. We're also flagging this individual for a musculoskeletal surgery. So that's a hip, knee, shoulder, spine surgery. And again, as we talked about earlier, if you get this person to physical therapy, that may or may not be an avoidable cost. I'll give you an example of what this looks like for an individual. We collect these from our customers. Obviously, Jane's not this person's real name. But we were able to identify Jane for becoming new high cost as somebody who was highly likely to engage. They had a bunch of conditions like the ones we just showed, musculoskeletal pain, mild, moderate depression, and so on. A lot of high risk for unnecessary use in the emergency department and high risk of not taking their medications correctly. So they were connected to a case manager who basically just realized that Jane's defaulting to the emergency department because that's how they know how to get care, and was provided alternatives for quick access to care, both urgent care as well as virtual care. And then also linked to a consistent primary care physician, because there was not, you can look, we also show, I don't show it in the actual plan, we show an entire timeline of what has been going on with the member historically over the last year plus, also of their medications. So that care managers can look in that and sort of understand, is this person connected to resources regularly? Are they actually taking their medications regularly? So Jane was connected to both primary care and mental health care, and also the nurse case manager went over their medications with them. So the consequence of that is improved mental health for Jane, consistent provider relationship, better understanding of how and when to take medications, and a reduction in ED spend from $25,000 to $1,000 a year. This is a win-win scenario, right? I'm going to scale that up a bit. So if we look back at that million member population, over the course of the year, we would only find about 2% of the population that really fits that very valuable, like proactive outreach that we can currently identify. We do not find everybody today. We find what we can that we're confident in. We actually specifically go through a process to threshold our predictions when we're talking about driving interventions, so that we want to be right 80% or more of the time. Because if you're going to drive an intervention toward that person, you want to be confident that it's correct. So that 20,000 patients represents an opportunity of like $135 million plus in avoided medical spend. You will not get to them all. There'll be bad contact information. There'll be people who don't pick up the phone. There'll be people who switch jobs and aren't on the plan anymore. All those things happen. Let's just say you can get to 20% of them. That's a reduction in medical costs of $27 million that we all collectively benefit from the increased efficiency in healthcare. That number you see at the bottom, that $564 per member per month, that's the key number in this funnel. And that's the result of studying. It's an observational cohort study that we run with our customers for one of them for 4.5 years now, where we look at people that we've prioritized, that we've actually gotten outreach and engaged with care management, and we compare them to a control group. And that's all across all lines of business, which might not mean, don't know how much that means to you guys, but think, fully insured commercial health plans through your employer, Medicare Advantage plans, Medicaid plans, individual market. There's a little bit less, that number's lower for employer groups. It's more like $200 per member per month, and higher for Medicare, it's more like $1,000. Oh, I guess I went fast, because this is my second to last slide. So in care and condition management, we have over a 3-year period reduced medical spend by $30 million. A lot of that's driven by reductions in inpatient admissions, ED visits, improved medication adherence. On the financial risk management side, where we help plans price business, we are significantly more accurate than current solutions. As you can see, they're 3x more accurate than what one of our customers was using. And on the patient engagement side, where we drive patients in to try to get into programs, health plans have a lot of programs that nobody actually takes them up on. Like uptake's like 3% of the people they do outreach to, not the population. We've boosted digital engagement in those things by 60%. We've increased telephonic engagement on our cases that we prioritize by 20%. And that's it. I bet you have questions.
All right. Yes. Lead us off, Michelle.
Thanks, Dean. That was awesome. Is this on?
Yep.
Yeah, thanks, Dean. That was awesome. I wonder if you could share any insights or have started to look at some of the systemic differences that you might be seeing. So I'm thinking about when you're looking at that propensity to engage score, are there gender differences there? What are some of the things that you've noticed at a high level that could be worked on from other angles?
There are gender differences. There's also age differences. And both of those feed into the models that we use to predict the engagement. There's also differences. This was a fun one. People who call their health plans are more likely to answer calls from their health plans. So one of the things that we asked for, aside from just historically, who did you do outreach to and did they respond, is can you please just give us your customer service calls? That was a surprise.
I'm going to add one if you don't mind.
All right.
So
Larry's prerogative.
Yeah. Some of those predictions could be used in ways that might not be so good for the patients. Mm-hmm. So, for example, if you're going to predict people who are going to be high cost, maybe I try to exclude them from my coverage next year.
Yeah.
Do you have any requirements on your customers of what they can and can't do with your data or with your predictions?
Yeah.
And how do you enforce them and how do you set them?
Well, the one you're worried about, it's not a requirement for me. It's a requirement in the ACA. So you can't individually write people out of health plans anymore. So when they are pricing new business, and in this we mean an employer group as a whole, let's say University of Colorado wanted a quote for all its employees, right? They have the choice to take all of them or none of them. And that it's nowhere in between. And then in the individual market, like let's say you go to your state's website to sign up for the individual market, thing that most people call Obamacare, there's no underwriting. You can't change the price on anything other than age and gender. And so the prices are set with the state and they're fixed. So you can't deny coverage, but what you probably are also concerned about is denying care. Although our stuff, these things, they go into feed proactive outreach, right? They're not used in any what's called utilization management decisions. No.
What
Let's
are
go
you?
over. Yep.
What have you learned, or what do you do to? What have you learned from studying single payer systems like Canada or NHS and UK, which has multiple tiers, but and what do you do to help think about an eventual U.S. future that might include a better single payer.
Yeah, I'd
option.
love to get the data from a single payer system because the data that we get is so just like we see anything that's inside of the health plan, maybe, right? If the person's covered on that plan for some period of time, but it's so broken up and fragmented, and then the care as a result is so broken up and fragmented. I mean, then even like the health system itself, like let's say you go to a Kaiser for surgery or whatever, and they have to do a special operation at a Dignity Health Center because that's where they got the OR that does, like they get no information sharing in our system. And I think it leads to some really bad results.
Piggybacking on that, you had mentioned that your lag with claims is long, and I know in working in our care network, that can be a year or two, so you're always working in the rears. Is there any move with your company or training models to use active medical records, like a partnership with Epic or some of these large systems which are acquiring data at incredible rates on all of these different aspects?
Yeah, we are always in the business of acquiring more data. And faster, which is better. One of the things I most want is what's called an ADT feed, because right now, because of the claims lag, if I were to predict a patient is going to be readmitted for the same diagnosis, it's totally useless. And we do get EMR data from one of our customers, but I want a lot more. Like I actually want that kind of integration. Epic is not the easiest to get that data from. I would have a lot more luck with potentially like some others in the industry.
Yeah. Thank you, Dean. Thank you, Dean. You are open to contract from just about anybody for this data?
To send you the data?
Well,
I mean, predictions.
For the predictions, yes.
The predictions.
Okay.
Yeah.
Okay.
Yeah, but there are limitations on what I can or can't do depending on the data you supply.
All right. I know you said telephonic. I have a couple of questions here. The cost of the telephonic, because if you're scouring any of the EHR records, the ESTOs are essentially the last thing that any doctor, MA, or PA fills in at the bottom of the record. So it's kind of scarce information, even though CMS loves it. So I wonder what the cost of the telephonic and trying to capture that. And do you identify, if someone asked, by the psychographic demographic by zip code and saying, "What I'm looking for this." And can you create a content curated report for that?
For a geography?
Yes.
Yeah. In fact, we also do them for employer groups as well. Yeah, we can surface like, I think X% of this population in this geography or within a group of people are going to show up in the emergency department, in the inpatient, seek care for XYZ conditions. We can provide a benchmark comparison as well.
How are people's information held private, and what do you do with HIPAA? Because
this all has to be under HIPAA use. So in this context, if I'm providing member level information back to one of our customers, it's because they are managing that population. They're providing care. Otherwise, we can't do it. There are some use cases that we have where we can provide aggregate group level information, but that's really for pricing, which is allowed under certain underwriting constraints. But no member level information in that context. You do have to be aware of it. Be cautious.
We'll come down here.
Okay. Yeah. Thanks for an interesting talk. I'm going to focus kind of at the, I don't want to say the back end, but at the foundation, which is the data, which always concerns me a little bit. And I'll go through a number of things, and maybe you could respond. For those who talk about medical records, at least in my experience in New York, nobody trusts the medical record at all. But that's another thing. The clinicians don't, and for good reason. But you bring in a variety of different data, and context is everything in healthcare and biological data. So perhaps you can talk to a couple of concerns that I have. Number one, in the United States in particular, lab data generated by different labs, and in fact, I've seen really interesting studies that look at intra-laboratory results are not comparable. And there have been decisive, it's largely driven by industry vested interests to stop any efforts towards harmonization, whereas in the EU and the UK, we have that. Secondly, along the lines of live data, there are very interesting studies that have come out recently that show that ambient temperature prior to getting the bloods drawn up to 4 days actually significantly affect the results, so much so that they can trace back the differences to differences in prescribing patterns on the part of doctors. So that's ambient temperature, both in the environment I live in, but different environments tend to have also different ambient temperatures, okay? So that's a question. So how do you deal with that?
Yeah.
Then if you look at claims data, very clear, and that's why models tend to be very context-driven, is the methodology used by providers to generate the claims can change.
Oh, yeah.
And if they change, how do you know they've changed? And how do you know the impact of that change on the data? And again, the central challenge here is that the data that you're looking at, we're not looking at apples and apples. They may be the same number, they may be the same test, but we're actually looking at apples and oranges. And so they're not, at least in my old-fashioned training, are not comparable and therefore problematic from a scientific analysis perspective.
Yeah.
Perhaps you could talk to that.
So
A real softball for you, Dean.
Oh, yeah, easy. Those are all totally reasonable concerns. And like the data we get from our customers, it's all over the map, right? And even the lab data is some of the hardest to even work with. But the way we handle this is we try to learn from the data to predict an outcome in such a way that we can test and validate whether or not the prediction is correct.
So you have a model going forward, and that model is highly context-driven, and you can't measure or identify the context.
You'll have to.
Yeah. So, but you have to think about it like we track performance of the model, right? And then we regularly retrain and relearn from the data because we know it's changing. And I'll give you a great example. This doesn't happen anymore under the METIS model, but in the XGBoost models, if you took customer A, let's say they're in the Southeast, and you train a prediction for who's going to show up in the emergency department, and then you try to transfer that model to customer B, let's say they're in the Northwest, the model completely underperforms. And if you look inside why, like let's say this model had about 12,000 features, fully 10,000 of them come out as zeros in the other population when you try to transfer that model over. And that's just because like the model learned on that data set is able to predict correctly on that data set, but when you try to move it to a different context, it doesn't work.
Okay, next question.
Hi, thank you for the really interesting talk. This is more to piggyback off of the first couple questions regarding your patients that were likely to engage. I was wondering if you've specifically looked at the population where the physicians kind of predict a high intervenability score on them with those that are unlikely to engage to see if there are certain structural things such as access to technology that could be provided through community organizations to better impact this population?
No, I haven't, but I think it's a very interesting question because we also have, as I just showed you, some of those other social risk scores, which are new. And you could probably ask that question in the context of those social risk scores as well, right? Is there something about these individuals that's a barrier?
Dare I even ask, have you applied this to fetuses? From my perspective of ultrasound and watching a lot of different, hugely expensive, since there's options in that demographic.
We only have one prediction that's related to high-risk pregnancy. And it's really focused, most of that data, especially, and this happens in healthcare claims data, it's tied to the mother. In fact, it's commonly tied to the mother all the way through the first year of age. It's like until they're almost a year old, the child doesn't get an independent member-level identifier for us to even track their data separately.
It seems like it might be a huge panacea of money saving.
Oh yeah, no, those neonatal claims are like a very expensive thing.
We've got our next question over here.
Thanks. So when Jane gets the phone call from the nurse, does the nurse say a giant AI model has predicted that in the next year you'll need a lot of care and also that you'll be responsive to my entreaties and stuff? Or is it just like a random phone call from her perspective?
I mean, from their perspective, it is a random phone call. We do training with the people who are going to do the outreach to help them understand these are predictions, and you need to lead. Using these predictions, you need to lead the person through an open conversation. about and you actually, mostly it's around letting them tell you what is going on with them, so you can figure out where they are willing to make change.
I mean, just thinking about Nelson's talk from yesterday in the cardiological context, where the prediction score is a motivator.
Yeah.
I mean, I think if I got a phone call from a clinician and they told me a giant AI model has predicted that you need to engage more with your healthcare in the next year, I would probably do it.
Yeah, but that's in your example, which I noticed, it's your physician, whom hopefully you probably know, and not your health plan.
Yeah, very interesting. Yeah.
That's a good point. While we wait for another question, do you want to talk? I didn't see a lot conveying confidence in estimates, and certainly not all estimates are equal. So could you talk a little bit how you convey uncertainty?
So let me just, maybe a good way to talk about this is with our customers, something we often start with is a proof of accuracy. We actually write it directly into the contract. So we'll take 3 years of historical data from them, and we will predict an outcome on a held out 4th year. And we'll tell them how accurate we think we're going to be on that. And then we let them validate it blind. And then we want the data afterwards. We do that because there's no reason you should believe that our model is more accurate than the other stuff. Like, health plans have been sold a ton of analytics over the last several decades, most of which has not worked. And so they are extremely reluctant and doubtful buyers. So this helps to get over that.
Thank you.
Hi, over on your right. Have you, 2 questions. One is, have you looked at using wearables as an input? And
I want it. Can I have some data?
Well, and then the follow-up question is what are the data types that you don't have that you think would most improve the model?
So I want much more to one of the questions earlier. I want richer and more real-time EMR data, and I want wearable data as well. And I was very interested in what I heard about the Soma scan earlier. Would love to get real-time protein sampling from people. If we could tie that up to longitudinal records, I think there's a lot of power in that. And I mean, you probably, maybe this was or wasn't transparent. These are not diagnostics, right? I'm not giving you a diagnosis. I'm saying, I think you have this future risk. Please go get in and seek medical care. And we're leaving that up to clinicians to actually do. And so we're not at that level, but maybe with that additional correct data sources, we could get there. The wearable data is messy, though, by the way. You really got to decide what you're going to do with it and how you're going to triage if anything looks odd.
Thank you. Any additional questions?
What's that? Wearables like your watch, your blood pressure monitoring cuff. Yeah.
All right, let's thank Dean one more time.